Hello and welcome back for another in this series of short presentations. Today we're going to have a look at seizures and how we should assess and manage these presentations in the pre-hospital setting. So what is a seizure? Well, broadly, it's uncontrolled abnormal activity of the brain. To use a cardiac analogy, we might describe it as like a brain arrhythmia where normal conduction across neurons becomes disorganized. This abnormal activity can be localized to a single area within the brain in what we'd call a partial seizure, or it can be generalized, affecting most or all of the brain at once. And to follow on with the cardiac analogy, a partial seizure might be likened to AF, affecting only like the top portion of the heart, the atria, while a generalized seizure might be more comparable to a ventricular fibrillation. Now, being the brain, that thing that controls our entire body, disorganized activity in various regions can lead to wide and varied seizure presentations. And this can look like anything from brief periods of absence to the classic presentation of full body jerking. It can even result in bizarre and unusual repetitive movements while the person experiencing them remains sort of primarily conscious. They can be brief and self-limited, or they can be protracted, requiring pharmacological intervention to stop them. There are many varied causes for seizures, from neurological conditions such as epilepsy to head trauma, infection or poisoning, just to name a few. But at the end of the day, regardless of the cause, each results in the same physiological processes at the cellular level within the neuron. When seizures either rapidly recur or fail to self-terminate, a patient may be said to be in status epilepticus. Previously, this has been defined as a greater than 30 minutes of seizure activity, but more recently there's been an international trend towards a more conservative definition of a single seizure lasting greater than 5 minutes or multiple seizures without a full return to consciousness in between. And this is because there's good evidence that the longer a seizure lasts, the more refractory it becomes, sort of making it harder to terminate with our first-line medications. When you consider the time it takes for someone to call 000 in response to a seizure and the ambulance response times, it's probably likely that any patient we see who is still seizing on our arrival at the scene is in status, actually. These patients can be very difficult to manage too if they're unresponsive to our first line medications. So these are the presentations we'll try and focus on here today in this presentation. To get an idea of what's happening inside the brain to cause a seizure, we need to dial it right into the neuron. When these are functioning normally, an action potential is sent down the axon to the dendrites, which synapse with the connecting neuron. These dendrites contain little vesicles which are filled with neurotransmitters such as glutamate, which is excitatory, and GABA, which is inhibitory. These neurotransmitters are maintained in a balance so that orderly transmission of action potentials between neurons can occur. However, when this balance is lost and there is either too much glutamate or too little GABA in the synaptic cleft, the rate at which neuronal action potentials are generated will increase. When this happens across lots of neurons all at once, a seizure will occur. And as that seizure continues, the inhibitory GABA receptors that are expressed on the membrane of the postsynaptic neuron progressively withdraw to within the neuron itself, while excitatory NMDA receptors are increasingly expressed. So this leaves less receptor targets available for GABA and further shifts that balance towards excitation. And this is the mechanism by which the seizure becomes sort of more refractory to GABA agonists such as benzos, the longer the seizure progresses. What this means for the rest of the patient is an assault on multiple body systems via various mechanisms all at once. Prolonged seizures can result in airway issues, either through anatomical occlusion or obstruction with vomitus or blood from a bit tongue, for example. Aspiration may impede their normal ventilation, as will the generally sort of rigid tone of the chest wall during convulsions. Hypoxia may lead to cardiovascular instability, and continuous use of large muscles will create a significant amount of cellular waste. And that will result in acidosis and hypothermia, which then in turn further impedes the delivery of oxygen to the tissues, if you look at your oxyhemoglobin dissociation curve. Both blood glucose and glycogen stores may be depleted, resulting in like a hypoglycemia, and there may be even just physical injury associated with the violent convulsions. It's important to note that there is also damage caused to the neurons themselves by the repeated generation of action potentials, and that occurs independently of things like hypoxia or these other mechanisms that we've discussed here. So when you're presented with a patient who's presenting with a partial seizure, you need to remember that even that partial seizure can cause damage to the neurons, irrespective of any sort of jerky motions. And we mustn't forget that when we're considering whether to intervene in those cases or not. In a patient presenting in status, assessment and initial stabilisation should occur simultaneously. Using a fix it as you find it sort of process, it's important to work through the ABCs and correct issues as you go. So initially, clearing and protecting the airway, and assessment and support of adequate ventilation are pretty critical. In a patient still seizing, the very next priority should then be the termination of the seizure. The drug of choice within my service is midazolam, which is a benzodiazepine. It's widely used as the first line agent for seizures. Once you've administered that, or if the patient is presenting in a postictal phase or between seizures, that's when you take the opportunity to assess vital signs in more detail. Like you certainly wouldn't muck around trying to get a 12 lead or even really a BP on an actively seizing patient, because your focus after the A's and B's should be on not delaying administration of your benzo. Once that's on board, then you can work through the rest of your vital signs survey, some history taking, with a focus on trying to identify causes and abnormalities you can easily correct, such as low sugars and things like that. Once you've completed that initial stabilisation phase and gathered a baseline set of vitals, you would then want to start looking a little deeper. There are lots of reasons a person could find themselves in status, and even if the patient has a history of epilepsy, that doesn't mean there isn't something more sinister going on. And our next set of investigation should be geared primarily towards finding those causes that we can fix. It's very important to get a good history of the events immediately prior to the onset of seizure, because this will allow you to prioritize those investigations that you want to take next. A slow decline into unconsciousness prior to the onset of seizures might lead you towards a toxicological cause, in which case you might prioritize a 12 lead to look for signs of TCAs, for example. On the other hand, if the patient was witnessed to suddenly drop in the street, we might prioritize things such as assessment for TBI, stroke, or intracranial bleed. A deeper history might give you clues as to the patient's history of alcohol use, and if they've recently given up cold turkey and put themselves into withdrawal. Or there might be a history of headaches that would lead you to look for signs of meningitis or sepsis. And of course, you need to consider whether the patient might be pregnant, which even in the third trimester might not always be that obvious, depending on things like body habitus. And where we identify one of those potentially rectifiable causes, this will guide our second and third line of interventions. And we might add sodium bicarb in TCA overdose, antibiotics in sepsis, or magnesium in eclampsia, for example. These assessments also help to guide your decision making around where to transport your patient. Your local hospital might be completely capable of managing a TCA overdose, but a patient presenting with eclampsia or a TBI might be better cared for at a specialist facility, and you might need to consider where your proximity to that facility and whether you need aeromedical retrieval, for example. Okay, so we have already mentioned the use of benzos as our first line management in seizures. So let's have a look at how they work to actually stop a seizure. These here are the GABA receptors, which we looked at previously. They sit in the membrane of the postsynaptic or the receiving neuron. We can see that our benzo in yellow is fairly interchangeable with our endogenous GABA, which is degranulated from the vesicles of the presynaptic or the sending neuron. Benzos attach to these receptor sites and activate them in the same way as GABA does. So benzos are a GABA agonist, so they're a GABA activator. And as we've discussed, GABA is an inhibitory neurotransmitter, meaning that activation of GABA receptors will allow an inward flow of negatively charged chloride ions, which decreases the voltage within that neuron, taking it further away from its threshold for propagation of an action potential. Now, if you remember that the longer a seizure continues, the more of these GABA receptors retreat back within the neuron, providing less targets for our benzos to hit. So that's where it becomes pretty clear that we need to intervene as early as possible. And that's why we would administer our benzo agent as part of our initial stabilisation process. Once the bulk of these receptors has retreated into the neuron, we'll find we need much higher doses of benzo to flood the remaining receptors, or we need to switch to a second line agent to target other receptors and come at the problem from another angle. There are a number of medications which can be used as a second line intervention, and each one of those works via a different mechanism. Levetiracetam, also known as Keppra, is quite commonly utilised as it works independently of GABA pathways. Rather than increasing inhibition, like GABA does, it decreases excitation by inhibiting the calcium channels which trigger the degranulation of glutamate from those presynaptic vesicles, and this prevents stimulation of the receiving neuron. Other second-line agents include valproic acid, which we commonly see as sodium valproate or Epilim, and other medications like phenytoin, with each working via a different pathway to either decrease stimulation or increase inhibition. Unfortunately, these agents aren't routinely available to us at the roadside, so when we're faced with a patient in refractory status, it might be worth early consideration of where they might be available, either through physician support on scene or at a medical facility. If you're lucky enough to carry these in your toolkit, you should be looking to administer an alternate agent after the second dose of benzos, because we know that with the timeframes involved here, those benzos will be rapidly losing their efficacy. When second line interventions have failed, or you don't have them available, your next step may be to proceed to RSI. A ketofol induction, that is ketamine and propofol, is preferred, because both these drugs have anti-epileptic actions in their own right. Propofol works as a strong GABA agonist in a similar way to benzos, and ketamine is an NMDA receptor antagonist, which blocks the binding of the excitatory neurotransmitter glutamate to the NMDA receptors on the receiving neuron. If we think back to our pathophys on this, we'll remember that while those GABA receptors are receding during a prolonged seizure, the NMDA receptors are being increasingly expressed. So if we can block the excitatory receptors while flooding the inhibitory receptors with GABAergic agents like propofol, we might be able to swing the balance back toward termination of the seizure. If we don't have propofol or even RSI in our toolkit, we could consider trying to achieve the same sort of thing with ketamine and higher doses of midazolam. We just have to be ready to follow that up with a tube in what would essentially become like a drug-facilitated intubation. And finally, in terms of the ongoing care of the patient, either in or post-status epilepticus, it's essentially going to be centered around achieving homeostasis. And that involves providing O2 or ventilatory support, maintaining adequate perfusion with fluids and vasopressors if they're needed, replenishing depleted glucose, and actively cooling any significant hyperthermia that's been generated through repetitive seizures. If your patient is anaesthetized, maintain your ongoing infusions of propofol and ketamine, and continue to manage any of those underlying causes for the seizure that you might have identified through your assessment. I just want to add a quick note on leadership here, because these cases can be quite stressful and very difficult to manage. As the lead clinician in these jobs, it's like super important to maintain a calm demeanor, even if you're sweating through your underpants, right? Like, keeping your head and voicing a stepwise plan to progress through a set of assessments and interventions will help bring some of that control back to what can at times feel like quite an out of control situation. Being clear about your priorities in management and being assertive with your early interventions will help you get on the front foot in terms of managing those seizures, and being realistic about what you can achieve on scene with the tools that you have at your disposal will help you decide whether you need further support at scene or if you really just need to get moving towards the hospital. Okay, so let's round this off with a quick case. You are an ICP and you've been called to assist a paramedic crew for a patient who is having seizures. They're just outside the city and approximately 30 minutes to a major hospital by road. On arrival, you find Joe. He's a well-known local with no fixed address. The attending crew advises that his mate called 000 and then left the scene. He's not keen for emergency services. When they arrived, Joe was actively seizing, but he stopped within about a minute or two of their arrival. He's now GCS 3, and he has been since the seizure stopped. The crew have managed to get a basic set of vitals, and they have an IV in situ. They advise Joe is known to suffer with alcohol abuse, but they don't know any more about his past medical history. And during their handover, Joe starts seizing again. And the crew are reluctant to administer the midazolam, preferring just to wait and see if the seizure stops again, like it did last time. So, what are our priorities here? We know that this guy's been in a bad way for some time now, given that he was still seizing when the initial crew arrived after that initial 000 call. He's been deeply unconscious since, and he's now seizing again. So what is this? This is clearly status epilepticus, and it needs to be managed. So you calmly verbalise this to your crew, and you explain your plan to the team. Your priorities will be protecting that airway and ensuring adequate ventilation, while simultaneously getting on board that first dose of IV midaz. You get a second dose ready, and you advise if there's no effect after 2 doses that you plan to administer some Keppra as well. And we'll proceed to RSI if that also fails. So everybody's on the same page with the plan from the outset. 15 minutes later, Joe is still seizing after 2 doses of midaz and some IV Keppra. At this point, you realise Joe is in refractory status epilepticus. You consider the 30-minute transport to hospital, plus the safety aspects associated with extricating and transporting an actively seizing patient, and you decide the safest course of action is on-scene RSI. You verbalise your intubation plan to your team and conduct the RSI with ketamine and propofol induction. Once loaded, your ongoing care is focused on a return to homeostasis and further assessment and management of the potential causes for Joe's condition. Finally, the hospital is pre-notified of your impending arrival, and there are crowds cheering you on for your outstanding efforts as you roll on through the door. And that is that. So thanks very much for watching this presentation on seizures. I hope you leave it with a slightly better understanding than you had in the first place. So bye till next time.